Welcome to all the participants. We have 45 logged in GoToWebinar participants. And today's topic is hepatitis C. The objectives of this webinar are to review the epidemiology of hepatitis C virus and the risk factors for transmission, describe the potential impact and burden of chronic HCV infection, discuss screening and diagnosis, and highlight challenges in the care of HCV-infected patients and guidelines relating to their treatment. Today's speaker is Dr. Franco Antonio Felizarta. He's my batchmate in the UPCM class of 1991, who is joining us from California, USA. He's an intermed graduate of the UP College of Medicine and did his residency in internal medicine and subspecialty training in infectious disease at the State University of New York in Brooklyn. Dr. Felizarta is a diplomate in internal medicine and infectious disease and a fellow of the American College of Physicians. He is a certified American Academy HIV medicine specialist and a certified physician investigator. He is a co-investigator in many published clinical trials on HIV and hepatitis C treatments. He's an active infectious disease specialist in Bakersfield, California, and a leader in the medical community. He's the chairman of the Infection Prevention Program, a director of the Antibiotic Stewardship Program, and currently a board of director at the Kern County Medical Society. He has received numerous awards from the community, among which are the Internist of the Year 2000 from Clinical Share Vista, Outstanding Contribution to the Community Award from Kern County Medical Society, and Physician of the Year in 2010 from the Kern Nurse Physician Assistant Practitioner Association of America. Webinar participants, please welcome Dr. Franco Felizarta.
So magandang hapon sa inyo lahat. Good afternoon to all of you. It's about 9 p.m. here in California. So I'm actually at home. I should be in my pajamas right now. But I would like to apologize in advance if you hear some background noise. I have 2 dogs. So you might hear some barking in the background. And I have 2 adolescents, so you might hear some uncontrolled laughter in the background. Anyway, thank you for taking the time from your busy schedule to attend this webinar entitled Hepatitis C, the Hidden Epidemic. I have about 25 slides, and we'll try to finish this in 20 minutes. Yeah. So let's start with the learning objectives. So we have the usual epidemiology and risk factors for transmission. We'll discuss the potential impact and burden of chronic hepatitis C infection, which is really based on the natural history of hepatitis C. We'll discuss the screening, diagnosis, and the care of hepatitis C infected patients. But really, my goal for today is to convince the listeners that chronic hepatitis C is a major problem in the Philippines. It will not go away, it will get worse, but there is hope. So a little background. Hepatitis C virus infection was previously known as non-A, non-B. It's a clinical entity in transfused patients reported in the late 1960s and the early 1970s. It's actually a member of the genus Hepativirus and under the family Flaviviridae. Remember, dengue virus is a member of the family Flaviviridae. It was discovered in 1989. Unfortunately, there are no vaccines available at this time. The vaccine is very difficult to develop because multiple mutations would occur during viral replication, resulting in a substantial heterogeneity, and we call this quasi or quasi species. So let's start with the epidemiology and risk factors. So what is the worldwide prevalence? There are about 180 million individuals infected with hepatitis C worldwide. Compared this to hepatitis B, chronic hepatitis B, which is about 350 million, and HIV, which is about 40 million. Now, the prevalence in the United States is about 1.6%, which is about 4 million individuals. In the Philippines, according to the WHO 2002 data, the prevalence is from 2 to 4%. However, there was an update in 2007 showing it might be actually lower at about 1%. So we're talking about 1 million Filipinos with hepatitis C, and that's actually a lot compared to, for example, chronic hepatitis B, which is about 7 million in the Philippines. How about the worldwide distribution of the hepatitis C genotypes? Now, hepatitis C has 6 different major genotypes, and from another 5 minor genotypes. This is from 7 to 11, but 7 to 11 are actually minor genotypes under genotype 6. Now, each genotype has multiple subtypes. So, for example, genotype 1 will have 1A and 1B. Okay. In the United States, the majority of genotype is 1A. In Japan, the majority is 1B. In West and Central Africa, it's genotype 2. In India, genotype 3. In North Africa and the Middle East, including Egypt, the majority are genotype 4. South Africa is genotype 5. And Southeast Asia is genotype 6. The Philippines, however, has a different distribution compared to our Southeast Asian neighbors. The majority are actually genotype shared by genotype 1A and 1B, and the rest are genotype 2 and genotype 3. Now, this is important. We'll talk about genotype later, but this is important in determining the type of treatment. So what are the risk factors associated with acquiring hepatitis C infection? So there are 3 major factors. One is medical and dental interventions in healthcare settings with substandard infection control practices. I'm going to tell you, when I was an intern in Philippine General Hospital, that's probably from 1990 to 1991, we were not using gloves. We were reusing syringes and needles. Okay. Hopefully, I don't get a lawsuit for malpractice after this statement. But that's actually a major risk factor in the Philippines and outside of the United States and Europe. Second major risk factor is transfusion prior to 1995. And the reason for this is that the mandatory testing of donated blood in the Philippines was fully implemented in 1995. In the United States, it was fully implemented in 1992. So there's a difference of 3 years. The third major risk factor is injecting and intranasal drug use. PWID means persons who inject drugs. So in Hep C, we use this acronym PWID. In HIV, we use MSM for men who have sex with men. And then you have the tattoos, body piercing, and scarification, which is really a minor risk factor. Needle stick injuries and perinatal transmission, we will talk about that in the next slide. So this slide is showing the relative efficiency of hepatitis B, hepatitis C, and HIV transmission by type of exposure. So we already talked about transfusion, injecting drug use, and unsafe injection as the major risk factors. And they have efficient transmission, as you can see here. Now, needle stick injury, the transmission rate for hepatitis C from a single needle stick injury is about 3%. HIV, compared to HIV, which is 0.3%, and hepatitis B is 30%. So the efficiency from a single needle stick injury, the efficiency of hepatitis C transmission is 10 times compared to HIV. 3% versus 0.3%. But hepatitis B is 10 times more transmissible than hepatitis C. Okay, 100 times more transmissible than HIV. Fortunately, we have hepatitis B vaccination. So if you're in a healthcare setting, it's a no-brainer. You need hepatitis B vaccination. How about sexual exposure? It's actually not common. In monogamous individuals, it's very rare to have transmission of hepatitis C. If I have couples, usually they will have different genotypes. So I know they didn't get it from each other. There's an increased risk, though, if you have multiple sexual partners, or if a person is having sex, if it's a man who has sex with men and HIV positive. Perinatal transmission is about 5%. The transmission rate is about 5% from mother to child. So let's go to impact and burden. Is actually just based on the natural history of chronic hepatitis, hepatitis C virus. So this slide is showing you the natural history of the hepatitis C progression. So after an acute infection, about 20% of patients will have spontaneous resolution. If a patient has HIV, the spontaneous resolution rate is even smaller, about 5%. Now remember, after spontaneous resolution, there's no lifetime immunity. The patient can be reinfected with the same genotype or even subtype. So 80% will have chronic hepatitis C infection. So really the most important thing to remember here is about 30% of these patients with chronic hepatitis C infection, up to 30%, will develop cirrhosis of the liver in about 20 years. 30% in about 20 years. And after 5 years, about 25% will develop liver failure and cancer. That's on the average. Again, this cartoon, how chronic hepatitis C infection can lead to the development of fibrous scar tissue within the liver. And over time, the fibrosis can progress, causing severe scarring of the liver, and this is what we call cirrhosis of the liver. And eventually, it will lead to liver failure or hepatocellular carcinoma, cancer of the liver. Now, how do you know the patient has liver failure? One is ascites, when you have fluid in the peritoneal cavity. Another one is bleeding gastroesophageal varices, like almost having hemorrhoids of the esophagus. Hepatic encephalopathy, when you have confusion leading to coma. And jaundice, of course, when you're yellow or you have icterus. Now, this slide is showing the projected numbers of liver failure and cases of liver cancer through to 2020 in the United States. Okay? So by 2020, about 100, the United States will have about 150,000 cases of liver failure per year and about 14,000 cases of cancer, liver cancer, secondary to Hep C per year by 2020. Now, this is based on 4 million individuals with hepatitis C. Now, the Philippines, based on the 1% prevalence, will have 1 million individuals with hepatitis C. So this is not scientific, it's probably pure speculation, but there's a possibility that in about 10 years from now, the Philippines will have tens of thousands of cases of liver failure secondary to hepatitis C and thousands of cases of liver cancer from secondary to hepatitis C. This is in addition to chronic hepatitis B. Now let's go to screening and diagnosis. This is a testing, this is the hepatitis C infection testing algorithm for the diagnosis of asymptomatic persons. Remember, it will be very rare to diagnose acute hepatitis C. Most of these patients will have chronic hepatitis C because most patients will be asymptomatic anyway. The screening is very important, depending on the risk factors. So for exposure, to test for exposure and for screening, we use an hepatitis C antibody testing. If it's negative, then you can stop unless the patient has a very recent exposure, then you have to check the hepatitis C antibody again in 3 to 6 months. Now, if the hepatitis C antibody is positive, then you need to have nucleic acid testing for hepatitis C RNA by PCR or polymerase chain reaction. If this is positive, then it's time to refer to a hepatologist or a GI specialist, gastroenterologist, or even infectious disease specialist, a infectious disease specialist who would treat hepatitis C. But most of the physicians who would treat hepatitis C with extensive experience will be hepatologists. If it's negative, then you have to retest in 6 months to confirm that the patient really has infection of hepatitis C. So these are the 3 virologic markers that are clinically useful. We use anti-HCV antibodies for to test for exposure. This is our screening test. This is a marker of past and present hepatitis C infection. Hepatitis C VRNA, which is a direct marker of hepatitis C V replication, this indicates present active hepatitis C infection. So we use this for diagnosis. So antibody is for screening, hepatitis C RNA is for diagnosis. And of course, hepatitis C genotype, we already discussed about this. This is important because it will determine the type of treatment. Staging of fibrosis in chronic viral hepatitis. This is based on liver biopsies. There are 5 stages, 0, 1, 2, 3, and 4. Okay, the 0 is no fibrosis, then mild, moderate, severe, and cirrhosis. Now, in the United States, we actually shy away from liver biopsies because of the potential for complications, and it can be very painful. So we have non-invasive liver tests now that can be good alternatives to liver biopsy. You have the MRI, FibroScan. I have a FibroScan in my facility because I do a lot of clinical trials, and blood testing like FibroSure. But these are very expensive testing. I would recommend computational methods like APRI-4 or the FIB-4. APRI is really the AST over the upper limit of normal, which is usually 40, divided by the platelet times 100. So if you get a score of, let's say, 2.0, that will denote stage 4. If it's 1.5, that will denote stage 3. Okay. We can, in the question and answer portion, we can talk about these computational methods. Treatment challenges and guidelines. So the goals of therapy, the primary goal of therapy is to eradicate the virus, to cure. We can cure hepatitis C now. Of course, additional goals, there's no point of curing the hep C if there's no improvement in liver damage. We want to minimize the risk of liver cancer, enhance the quality of life, of course, prevent transmission of the virus, and reduce extrahepatic manifestations like liver, kidney damage, cryoglobulinemia, porphyria cutaneous tarda. Now, before we look at the medications for treatment, let's look at the viral characteristics of HIV, hep C, and hepatitis B. As you can see, the replication rate of hep C is between HIV and hep B. Hep B has the highest replication rate. The replication, for HIV, the nuclear replication, and there's a nuclear replication and a host genome integration. So the HIV virus becomes part of the human DNA. In hepatitis B, there's a covalently closed circular DNA. It's still inside the nucleus, though. But remember, hep C, though, is cytoplasmic replication. It's outside of the nucleus. That's why it's curable. There's no latent reservoir, and the mutations are not archived. So these are the virologic responses. This is based on the treatment with regulated interferon, which is usually 48 weeks. So if your virus becomes undetectable, usually less than 10 to 50 international units per ml, we call it a rapid virological response. That's the most important. If, let's say, after stopping treatment and the virus is still undetectable, even after 24 weeks, 6 months, we call it sustained viral response or cure. Okay. Suboptimal virologic responses, if the viral load does not decrease by more than 100-fold, we call it a null response. Partial is more than 100-fold, but not undetectable. Breakthrough is undetectable and it relapses during treatment. And the true relapse is detectable virus after stopping treatment. These are the milestones in therapy for hepatitis C. As you can see here, in 1991, we were using interferon as monotherapy for 6 months. The cure rate at the time, 6%, very low. 12 months of interferon, which is, we're actually doing 3 times a week interferon, 16%. With the addition of ribavirin, it actually increased to 42% where you give it 12 months. Now with pegylated interferon, which is a long-acting interferon, instead of 3 times a week, you give it once a week. With the addition of ribavirin, which is a pill, 200 milligrams, comes in 200 milligrams, you give it 3 tablets twice a day, 1,200 milligrams per day. Your SVR rate, or the cure rate, goes up to 55%. In the real world setting, it's probably about 45%. Now, this is the American Association for the Study of Liver Disease Treatment Algorithm for Hepatitis C Genotype. Well, as you can see, it's quite complicated. So we're not going to go into details. It's just, that's why it's very, if you diagnose a patient with hepatitis C, it's better to refer the patient to hepatologists who have extensive experience, because the algorithm can be quite complicated. And if the algorithm for treatment is complicated, the algorithm for dosing modification is even more complicated. We're not even talking about side effects here. With first few months, you'll get physical side effects, almost like flu-like symptoms. You're going to have fever, headaches, vomiting, diarrhea, generalized pain. And then the next few months, you're going to have mental side effects, irritability, depression, anger. So really, the first few months, you're going to be a pain specialist. And the next few months until the patient complete the treatment in 48 weeks, you'll be a psychiatrist. I actually treated more than 1,500 patients. Before 2010, there were periods where I have 50 patients on pegylated interferon at any one time. Imagine that, 50 patients on pegylated interferon. Worst period of my life, I think. You have calls from patients, you have calls from laboratories for laboratory abnormalities. Now, how about the new medications, the new direct-acting agents? So let's look at the mechanism of the actions first. So the first generation protease inhibitors, Boceprevir, Telaprevir, and Cimeprevir, they act on the NS3-4A viral protease here. And then the next class of medications they inhibit the NS5B polymerase. And one of this is Sovaldi, which is a brand name for Sofosbuvir, which is the generic name. And then the third class is the NS5A replication assembly factor inhibitors. So one example is Ribavirin, and you can combine 2 or 3 of this. So for example, Harvoni is a combination of Sofosbuvir and Ribavirin, and or you can have a combination that will act on 3 sites at the same time. So let's look at Boceprevir together with pegylated interferon ribavirin. I think for a while this was available in the Philippines. I'm not sure if this will still be available because they already stopped production in the United States. Anyway, the cure rate for this combination is about 65 to 70%. Not much of an advance over the Pegasus ribavirin. Also, if you look at this algorithm for treatment, it's even more complicated. Plus, it will add more side effects like rashes and even and severe anemia. Sofosbuvir, which is the NS5B polymerase inhibitor, is much better than the protease inhibitors. In combination with pegylated interferon ribavirin, you can have an SVR rate of 92% in patients without cirrhosis. This is the AASLD. This is our last slide, one of the last slides. This is the AASLD IDSA, the American Association of Society for the Study of Liver Disease and Infectious Disease Society America guidance. As you can see here, we have this combination of direct-acting agents that we use now. We actually don't use pegylated interferon anymore. And the cure rate of these combinations is more than 95%, and they have minimal side effects. What is the problem with this combination? One tablet, for example, of Litifispir Sofosbuvir will be $1,000. $1,000. So that's about $84,000. So in pesos, it will be about 4 million pesos. The good thing, though, is usually they'll give deep discounts outside of the United States. So the 4 million can be less than 100,000 pesos for 3 months, 12 weeks of treatment. So if you are really interested in the details of the algorithms of the treatment, these are my recommendations. So you have the excellent treatment guideline, the 2014 Hepatology Society of the Philippines Consensus Statement on the Diagnosis and Treatment of Hep C. Dr. Janice Ong, who will be our reactor later, actually is part of the group that created this consensus statement. There's the WHO has also guidelines for screening and treatment. It was published in 2014. And if you want the most updated versions, you can Google AASLD, IDSA recommendations, hcvguidelines.org, and this is updated every few months. So in summary, there are about 1 million Filipinos with hepatitis C. Genotype 1 is the most common genotype. Up to 30% of patients will develop liver cirrhosis in 20 years. The 3 most important factors, risk factors, are healthcare-related procedures with substandard infection control, transfusion prior to 1995, and injecting drug use. Hepatitis C antibody is used for screening, and quantitative Hep C RNA is for diagnosis. We need a viral genotype to determine the type of treatment. Okay, the treatment for type 2, type 3, type 1 will be different. And then for not fibrosis staging, I recommend the APRI, which is the AST to platelet ratio index. And most important, hepatitis C virus is curable. Interferon-based regimens have cure rates about 50% for genotype 1, but they have side effects, usually severe, while the combination of the new oral direct-acting agents have cure rates of more than 95% with minimal side effects. So hopefully the pricing will be decreased outside of the United States, because these are very expensive medications in the United States. That's why patients here in the United States, they will not be able to get medication if they have early stages of liver. Usually stage 3, stage 4 patients will get the treatment. Thank you very much.
Thank you, Dr. Felizarta, for the comprehensive lecture. Before we proceed to the question and answer portion, let us have we have one of our panelists to give his reaction. May I introduce Dr. Janus Ong, who is a magna cum laude graduate of biology in UP Diliman and a graduate of the UP College of Medicine. He is #1 in his class. He did his residency in internal medicine at Yale Primary Care Internal Medicine, residency and fellowship in gastroenterology at the Cleveland Clinical Foundation, fellowship in hepatology at the National Institutes of Health in Maryland, and master's in public health at Johns Hopkins University. He is a diplomate of the American College of Physicians in internal medicine, hepatology, and gastroenterology. He is a sub-investigator in several clinical trials on hepatitis C therapies and has many published studies and has authored several chapters. He's actually the #1 Filipino scientist based on Google Scholar citation. At present, he is a clinical associate professor at the UP College of Medicine and a consultant at PGH and the Medical City. Webinar participants, please welcome Dr. Janus Ong.
So the current slide shows the hepatitis C situation in the Philippines. And as Dr. Felizarta had mentioned, there's really not a good seroprevalence data in the general population. And probably the closest that we can get in terms of a general population data would be the one from OFW applicants. And in fact, in a very recent publication, there was an estimate of about a 0.9% anti-HCV seroprevalence, or in that publication, there was about 609,000 individuals who were anti-HCV positive. However, the number of individuals who were actually viremic or who had HCV RNA was not determinable. So there was no data on how many, but that's probably beyond 3/4 of these individuals who would be positive for anti-HCV. So it is, as Dr. Felizarta said, not a very small number, although it's smaller compared to the United States, and it is definitely much smaller compared to the number of people with hepatitis B in the Philippines. And as Dr. Felizarta had also mentioned, the most common genotype in the Philippines, which is not similar to the most common genotype in Southeast Asia, is genotype 1 infection. And then we have a sprinkling of genotypes 2, 3 infection as well. But genotype 1 would be the predominant infection. And Dr. Felizarta also showed you the evolution of hepatitis C treatment over time. And currently, with the all-oral medications, those that Dr. Felizarta mentioned in one of his last slides, we can now achieve cure rates of 95 or even 100% in some populations. So it really is a big advance in the treatment of chronic hepatitis C. So the available drugs in the country for hepatitis C are shown on this slide. We still have pegylated interferon alpha, both 2A and 2B. Ribavirin is still available. Boceprevir had, as Dr. Felizarta said, the local supply has also been discontinued, so we cannot access Boceprevir. In the next, actually, Sofosbuvir or Sovaldi, as Dr. Felizarta had mentioned, being an NS5B polymerase inhibitor, this is now approved in the Philippines, although it is not yet commercially available. They still have to launch the product. And the other product, which is a combination pill, combination Sofosbuvir-Ledipasvir, which includes the polymerase inhibitor and the replication complex inhibitor, that is already awaiting FDA approval. But for both of these drugs, we can access them through a compassionate use with the local distributor. So all we need to do is to submit an abstract for the patient, and as long as they're Filipino citizens, they can access the medications. And as Dr. Felizarta mentioned, the cost of the medication is significantly lower in the Philippines. And he's right, he's probably less than 100,000 pesos compared to the 4 million that you would spend, for example, for Sofosbuvir-Ledipasvir combination in the United States. So Dr. Felizarta showed you some recommendations on treatment. So in the Philippines, if you have a genotype 1, 4, 5, or 6 patient, you have just these options currently. Peg and Ribavirin, of course, are options, but they are not, the response rates are very inferior. So for genotype 1 patients, it would be good to get compassionate use of Sofosbuvir and Ledipasvir for those individuals. And for genotype 2-3 patient, they cannot be treated with the Sofosbuvir-Ledipasvir combination. So the ideal regimen would actually be the combination of PEG, interferon, Ribavirin, and Sofosbuvir, or Sofosbuvir plus Ribavirin. Just because our choices for drugs are limited by what's available locally. But as Dr. Felizarta mentioned, we have gone a long way from weekly injections, 17 to 18 pills a day, 24 to 48 weeks, and less than optimal cure rates, to 1 pill a day for 12 weeks with fantastic cure rates of more than 95%. And that's why, in the US, Pamela Anderson has already said she's cured of hepatitis C from these drugs. So challenges do still remain for the treatment of Hep C, and one of them is treating genotype 3 patients, either experienced or cirrhotic, and the patients that actually need it the most but are very difficult to treat, those with decompensated cirrhosis, those who are on dialysis with kidney disease, and those after liver transplant. And of course, in the Philippines, our other problem is access to treatment, because even though it's much cheaper, it's still not within reach of most Filipinos. Thank you.
Thank you, Dr. Ong. And we have a few questions from the participants. We have a question for Dr. Felizarta. Could you tell us the results of the latest clinical trials in the USA for hepatitis C treatment?
Right now, right now, I'm participating in clinical trials with Merck and Abbey. So Abbey has the NS5. These are second generation direct acting agents. These are pan-genotypic agents. So for example, Abbey has a pan-genotypic NS3A to NS34A plus the pan-genotypic NS5A inhibitor. And right now, we actually reported this in AASLD. 100%, 99 to 100% of patients have cure rates with 8 weeks of treatment. 8 weeks of treatment, and this is from 1 to 6. Now, these are patients. All of them have have cirrhosis, with or without cirrhosis, except genotype 3. So as Dr. Ong mentioned, genotype 3 is still a problem. But I think give it time, we will probably solve the problem with genotype 3, because even with genotype 3 cirrhotic patients with 12 weeks with the new combination treatment, pan-genotypic treatment, we can achieve more than 95% cure rate. So we are doing phase 2 trials right now. So hopefully with the phase 3 trial will confirm that.
Thank you very much, Dr. Felizarta. Those are very promising results. We have a question for Dr. Janus Ong. Recently, you have been asked by the DOH to be the lead consultant for hepatitis screening and control in the country. Could you tell us about the program that you are planning to implement?
Thank you, Leo. Actually, the Department of Health under the office of Dr. Belisario, Undersecretary Belisario, recently created a viral hepatitis program, which I think is a very important step in the care or care of patients with viral hepatitis in the country. Under that program, the idea is to come up with a comprehensive plan for the prevention and control of both hepatitis B and C, of course, for all viral hepatitis, but the main focus at the moment, because the morbidity is currently highest with both hepatitis B and C, will be on hepatitis B and C infection. So there are no concrete plans yet, but the wish is to come up with a plan that will include screening, diagnosis, prevention, and most importantly, treatment by increasing access of these life-saving medications to patients with hepatitis. And the DOH is very much interested in this, and there is a lot of ways to try to even lower the cost of hepatitis drugs currently, especially since my understanding is that the manufacturers of generic drugs for these medications are also interested in coming to the Philippines and sell their products here. So if that happens, we will definitely be able to bring down prices for hepatitis C medications in the Philippines, even further than what we can get them for at the moment.
We have one last question for both Dr. Felizarta and Dr. Ong. One of the webinar participants is interested if there are newer treatments now for hepatitis C. Hepatitis CA for hepatitis cancer.
Okay.
Pharmacological treatment.
Pharmacological
treatment.
Okay. This Franco.
Franco, Dr. Felizarta, would you like to answer it first?
So, sorry, what was the question again? It's newer treatments for... Sir, can you repeat the question again?
They want to know if there are pharmacological treatment for hepatic cancer.
Yeah, actually, there's a Nexavar. It's a medication that we use for hepatocellular carcinoma, but they're not in terms of efficacy. They're not, it's not really impressive. Really the definitive treatment for hepatocellular carcinoma is liver transplant. You can actually cure hepatocellular carcinoma. We use the Milan criteria for the liver transplant indication for hepatocellular carcinoma.
Thank you, Dr. Felizarta. Dr. Ong?
Yeah. So as Dr. Felizarta had already shown as well on his natural history slides, the dreaded complications for hepatitis C as well as hepatitis B is the development of liver cancer. There are treatments available now for hepatocellular carcinoma, and they include surgery, liver transplantation. In fact, hepatitis C is the #1 cause of liver transplantation in the United States. But in terms of oral medications, if that was the question, there is only one approved medication currently for hepatocellular carcinoma, and that is sorafenib. It is an oral tyrosine kinase inhibitor, which is not exactly chemotherapy, but it's systemic targeted therapy for the palliative treatment of hepatocellular carcinoma. But as I said, there are other treatment modalities for HCC.
Thank you, Dr. Ong. We have another question for you, Dr. Ong. They're asking in the Philippines, with the current blood screening method that we have for hepatitis C, is there a chance that you will acquire hepatitis C with transfusion?
Dr. Felizarta mentioned that after 1995, the blood screening testing strategies have been really firmed up with the Blood Donation Act of 1994. I think we have pretty good screening for hepatitis C in our blood supply. There are those who would like to think that we should be doing nucleic acid testing for our blood supply for all of the blood-borne viruses, but we just don't have the resources, I am told, to do that. But for now, the risk of acquiring blood-borne infections from our blood supply is very low, and it's very much acceptable.
Thank you, Janus. For Dr. Felizarta, there's a question that is there a difference in the treatment strategy of pediatric versus adult hepatitis C?
So the question is if there's any difference in the strategy for treatment of hepatitis C in adult patients and pediatric patients. At least for pegylated interferon, they're indicated up to 4 years old. So 3 years or below, it's contraindicated. So it will be the same strategy. It's just the dosing is different. The problem is the new direct-acting anti-agents, they're not really approved for pediatric patients. So we're going to have to wait for clinical trials on pediatric patients before we can use this new combination direct-acting agents.
Thank you, Dr. Felizarta. Dr. Ong, there's a question that in the Philippines, if you have hepatitis C and you cannot afford the mainstay of treatment, what other help can you advise this patient? Maybe they want to know if this is also covered by our PhilHealth.
So at the moment, PhilHealth does not have any coverage for outpatient treatment of viral hepatitis, either hepatitis B or hepatitis C infection. I'm trying to think if there's a way that we can access these drugs if one does not have the financial resources. But I think at the moment, we do not have a way yet because the drugs are currently not available in the country, meaning there's sofosbuvir and there's sofosbuvir-ledipasvir combination. Only sofosbuvir has been approved, but it's still not yet physically available, and we still have to wait for the approval of sofosbuvir and ledipasvir. But once these drugs, I think, are approved and they're in the market, we can certainly work until such time when the PhilHealth, when the DOH has a comprehensive treatment access plan, we can work with organizations like the PCSO who have been in the past been very generous in providing for help for the treatment of hepatitis C using pegylated interferon and ribavirin. So, but I think those drugs will have to be available first in the country before we can ask for assistance from organizations like the PCSO.
Thank you for the engaging discussion, Dr. Ong and Dr. Felizarta. As a summary, we learned that 30% of the patients with hepatitis C will develop liver cirrhosis in 20 years, and around 600 to 1 million Filipinos are infected with this disease. Then the most important risk factors are care-related procedures with substandard infection control and transfusion prior to 1994 and injecting drug use. Then the use of hepatitis C antibody is important for screening and quantitative HCV RNA for diagnosis. Then we learned that the use of APRI, the AST to platelet ratio index, or FIB4 scoring, is used for it can be used for fibrosis staging. HCV is curable. Interferon-based regimens have cure rates of about 50% for genotype 1, but side effects are common and severe, while new oral meds have cure rates from 90% with minimal side effects. There is hepatitis C in the Philippines, and around 600,000 to 1 million Filipinos are affected with this disease. And then it's recommended that we screen those with risk factors, especially the IDUs, and those with history of blood transfusion before 1994. We also learned that antiviral drugs are available in the Philippines, including those that are very effective in eradicating the virus, and they are available at a fraction of the cost compared to other countries. Aside from being very effective, these drugs are much easier to take in terms of the route of administration, the number of pills, and duration of treatment and side effect profile. And with the establishment of the viral hepatitis program that Dr. Ong mentioned at the DOH, it is hoped that more of these drugs will become even more accessible to many Filipinos. So after this session, an email containing a survey link will be sent to you. After answering the survey, your certificates will be sent to you. Please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thank you for joining us. Hope to see you again in our upcoming webinar on April 27, 12 o'clock noon to 1 o'clock p.m. Manila time. The webinar is titled Difficult to Treat Atopic Dermatitis with speaker Dr. Marisha Recto. Please invite your colleagues to join this continuing monthly CME webinar series. All webinar schedules and resources will be posted at www.upm.edu.ph/UP-Med-webinars. In behalf of the UPCM Class 1991 and the UP Medical Alumni Society, we would like to thank our collaborator units, UP Manila Information Management Service, the National Telehealth Center, the UP College of Medicine Postgraduate Institute of Medicine, and Medical Informatics Unit, the DOST ASTI, and Ms. Cherise Orhalio, our host. This is Dr. Leo Cobillan, together with Dr. Franco Felizarta, Dr. Janus Ong, and the UP Med webinar team closing this session. We hope you have learned from today's webinar. Join us again on April 27. Have a great week ahead. Thank you.